So, okay, good afternoon, everyone. Happy Deepavali. So, today we are here to discuss the 20 MCQ which were already given in your test. So, purpose is not only to discuss the MCQ, purpose is to discuss all the important topics which are important for your exam. Okay. I hope I am audible and visible. Everything is fine. Okay. So, I hope I am audible. Just send me one hi so I can understand. So, question number one. Question number one, a woman has a plasma osmolarity of 300 milliosmol per liter and a urine osmolarity of 1200 milliosmol per liter. What is the correct diagnosis? What is the correct diagnosis? What is the answer? Yes, SIADH, syndrome of inappropriate ADH, water deprivation, central diabetes insipidus, nephrogenic diabetes insipidus, or drinking large volume of distilled water. What is the correct answer? Please answer your diagnosis in the comment section. So you can see that urine osmolarity is very, very high. Urine osmolarity is very, very high. It is 1200 milliosmol per liter. And plasma osmolarity 300. What is your diagnosis? It cannot be diabetes insipidus, neither central nor diabetogenic. You know, in diabetes insipidus, we have dilute urine. So what is the correct answer? Yes. Okay. So answer can be between syndrome of inappropriate ADH and water deprivation. Water deprivation. So what is your diagnosis? You have 30 seconds to answer and then I will discuss that. Yes, Dr. Nina. A. Syndrome of inappropriate ADH. Yes, it can be the answer. A. Okay. Please everyone try to answer. If you are wrong, you will be corrected. If you are correct, it's good. So no problem in interacting. So most of you are saying answer is SIADH. So what is SIADH? You know, ADH is more in SIADH and ADH is less in case of diabetes insipidus. You know this. So you might be thinking ADH is more, so urine will be concentrated. But suppose if there is someone who is not taking enough water, if someone is not taking enough water, water deprivation, then water will also be less. Yes or no? So urine will be concentrated. In that condition, what will happen? Actually, this is a tricky question. Answer is water deprivation. See, because I am seeing the patient plasma and urine osmolarity both. Okay. But both are consistent with water deprivation. Why? Because plasma osmolarity is on the high side of the normal. Why? If you're not taking water, what will happen? ADH will also be very, very high, just like SIADH. So if I'm not taking water, again, same thing will happen. ADH will be high. But because of excess water absorption in SIADH, plasma osmolarity will go a bit down, not high. It will be right 285 or 290. But you can see plasma osmolarity is 300. Because 99% of case, we always see it is a diabetes insipidus or SIADH. But this is a tricky question. The only thing that can help you in differentiating between SIADH and water deprivation is the plasma osmolarity. Because if ADH is very, very high and you are not water deprived, more and more water will be absorbed. And if more and more water will be absorbed, plasma osmolarity can be a slightly on the lower side, not on the higher side. It will not be on the higher side. 290. From 290, it can become 280, not 300. So whenever in the exam you are getting option of SIADH along with the water deprivation, what you have to see? Plasma osmolarity. So plasma osmolarity is on the high side of the normal. stimulating the posterior pituitary to secrete ADH. Secretion of ADH in turn will act on collecting duct to increase water absorption and produce hyperosmotic urine. So I hope this is clear. SiADH. Of course, SiADH will also produce hyperosmolar urine, but plasma osmolarity would be lower than the normal because of excessive water retention. This is the key point to differentiate between SiADH and water deprivation. Then we know about the central and nephrogenic diabetes. See, ADH. If ADH is low, okay, what is that called as? It is called as central diabetes insipidus. It is called as central diabetes insipidus. So, of course, urine will be hyperosmolar. Urine will be hyperosmolar and plasma can be what? Sorry, in central diabetes, hypoosmolar. Urine will be dilute. Sorry, urine will be dilute. So urine will be dilute. Why? Because ADH is not there to absorb water. But if there is ADH is normal, but there is mutation of aquaporin 2 or V2 receptor, like the question that was asking you NEET PG examination, if there is mutation of aquaporin 2 or V2 receptor, it is called as nephrogenic. It is called as nephrogenic diabetes insipidus. So in central diabetes insipidus as well as in nephrogenic diabetes insipidus, urine will be dilute. Urine is going to be dilute without a doubt. Okay. But in case of central diabetes insipidus, ADH is less. In case of nephrogenic diabetes insipidus, can be mutation of either aquaporin 2 or V2 receptor. On the other hand, in case of SiADH, ADH is very, very high. ADH is very, very high. And if ADH is very, very high, what will happen? Urine will be concentrated. Urine is going to be concentrated. So remember, doctors, it's a very important point. Urine can be concentrated in both either SiADH or water deprivation. But the correcting point here is that plasma osmolarity will be a bit on the lower side in case of SiADH, but on the higher side in case of water deprivation. So answer is going to be B, water deprivation. Okay. Next question. A patient is infused with para-amino hippuric acid to measure renal blood flow. She has a urine flow of 1 ml per minute, a plasma hematocrit of 1 milligram per ml, a urine pH of 600 milligram per ml, hematocrit of 45%. What is her effective renal blood flow? Now, what mistake we made? We know already that renal plasma flow is equal to creatinine clearance of PAH, creatinine clearance and inulin clearance is used to measure GFR. But when they're asking to measure renal plasma flow, we will use the clearance of para-amino hippuric acid, and that will be substance in urine upon substance in plasma into urine flow rate. This you know already. So whenever they ask you to calculate renal plasma flow, not the blood flow. Okay, this is the blood flow. Okay, so if they ask you to calculate plasma flow, what will be answer? You can see here. What is the answer? 600. Answer will be 600 because both are 1. 600 in the urine upon 1 into 1. Answer will be 600. But mind it, doctor, it is renal plasma flow, not the blood flow. And you know renal blood flow is equal to plasma upon 1 minus hematocrit. This we forgot in the exam. So please, what the point you have to aware in the exam, they are asking renal plasma flow or they are asking renal blood flow. If they are asking renal plasma flow, the only thing you have to do is that substance in urine upon substance in plasma into urine flow rate. You can see here, it is 600. But when they ask you about the renal blood flow, answer will be plasma upon 1 minus hematocrit. How much is hematocrit? 45%, so 0.5. So it will be 600 upon 0.55 and answer will be 1091. Answer is going to be 1091, not 600. Because when we are in a hurry, when we are not thinking a lot and we are not prepared for this question, we always know renal plasma flow equal to creatinine clearance. No, It is the clearance of para-aminohippuric acid. Remember, creatinine and inulin are used for measurement of GFR, not for renal blood flow. But if they're asking about the renal blood flow, then it will be plasma upon 1 minus hematocrit. Plasma upon 1 minus hematocrit. Is this clear? Now, next question. Tendency for edema to occur will be increased by. Edema, what is edema? Amount of fluid in the interstitial space. Amount of fluid in the interstitial space. Is it arteriolar constriction, or it is increased venous pressure, or it is increased plasma protein concentration, or muscular activity? Question is that in which condition we can have edema? Arterial constriction. If there is arterial constriction, hydrostatic pressure will be less. Hydrostatic pressure will be less. So filtration will be less. So tendency of edema will be more or less. Tendency of edema will be less. If you constrict the arteriole, okay, if you constrict the arteriole, what will happen? Okay. So let me make a diagram before this. See, edema, what is edema? Edema occur where more fluid is filtered out of capillary than can be returned. Filtration is increased by change that increase in hydrostatic pressure or decrease. Arterioconstriction will decrease pressure and decrease the filtration. It will decrease the pressure and decrease the filtration. Okay? Decrease the filtration. Dehydration would increase plasma protein. But this is very important. When there is a dehydration, plasma protein concentration will be increased, and that will increase the retention. More is the oncotic pressure, more is the retention. But increase in the venous return or increase in the venous pressure would increase your pressure and filtration. Now you need to remember the diagram. Only by this diagram you can understand all questions regarding filtration and edema. Hydrostatic pressure. See, this is your blood vessel. Okay, this is your blood vessel. Suppose, let me make it. If there is more hydrostatic pressure, in the capillary, filtration will be more or less. Filtration is going to be more. If there is more oncotic pressure in the capillary, what is oncotic pressure? Oncotic pressure means retention power. It is because of the albumin. So more is the albumin, more will be the retention pressure, and more will be the water in the capillary or water in the interstitium, water in the capillary. So it will cause opposite movement. On the other hand, hydrostatic pressure of the interstitium will cause filtration on the direction of capillary, and oncotic pressure on the interstitium will cause more and more filtration. This diagram is very important for any question in your exam that is asking about edema. So net filtration pressure will be equal to hydrostatic pressure of the capillary minus hydrostatic pressure of the interstitium plus oncotic pressure of the interstitium minus oncotic pressure of the capillary. It is called as net filtration pressure. If this pressure is positive, more will be the filtration and more will be the edema. So coming back to the question, arterioconstriction will decrease the filtration to less edema. Increase venous pressure, more blood is coming in your capillaries, more will be the filtration. It can cause edema. Increase plasma protein concentration. Increase in the plasma protein concentration will increase oncotic pressure. Muscular activity will increase the lymphatic blood flow. So if lymphatic blood flow is increased, automatically edema will be decreased. Because muscular activity and massage are helping you to filter out what? To filter out the lymphatic. So edema will be less. Sometimes physiotherapy is used to decrease the edema because of the muscular activity. And the last is the pulsation of the blood vessel. Pulsation of the blood vessels also pulsate so that they can increase more and more lymphatic blood flow. So these questions are small, you can say. They are tricky type of questions. Question number 4. Inspiration split the second heart sound because. What is your answer? Aortic valve closed before pulmonary valve during inspiration, or pulmonary valve closes before the aortic valve, or mitral valve closes before the tricuspid valve, or tricuspid valve closes before the mitral valve, or filling of ventricle has fast and slow component. What is the correct answer? Yeah, doctors. What do you think is the most appropriate answer for this question? Physiological splitting. We have different types of splitting: physiological splitting, fixed and wide splitting, variable splitting. But in this question, they have asked about the physiological. When you are inspiring, normally we have lub and dub. Lub is S1, dub is S2. But during inspiration, who will come earlier? Aortic component. So A2 will come earlier, P2 will come late. So dub will be like a splitting. So we have splitting in the dub. It is called as aortic valve will close before the pulmonary valve. So we can see in this question, second heart sound is associated with the closure of aortic valve and closure of pulmonary valve. We know this point. Second heart sound is due to closure of aortic valve as well as pulmonary valve. Okay. So during inspiration, more blood flow. Earlier will be the closure of aortic valve. So aortic valve will close first, pulmonary will close later on. So there will be a S1 and S2 will have two components. One will be A2, other will be P2. So this splitting is called as physiological splitting. Okay. So answer will be what? Answer will be A. Aortic valve closes before the pulmonary valve. Now, during exercise, total peripheral resistance decreases because of effect of. During exercise, total peripheral resistance decreases because of effect of sympathetic nervous system on splanchnic arteriole, parasympathetic nervous system on the skeletal muscle, local metabolite on the skeletal muscle, local metabolite on the cerebral arteriole, or histamine on skeletal muscle. What is your answer? What is the best answer you have? Yes, doctor? Okay. Let me explain you one very important point. There are two types of exercise. One is called as isotonic. Other is called as isometric. One is called as isotonic, other is isometric. Yes, Swamiti, what is your answer? Answer is C. Very good. Local metabolite on the skeletal muscle. You are absolutely correct. Answer is C. Now, during isotonic exercise, if exercise is mild, it will increase your systolic BP and diastolic will remain normal. But if exercise is moderate to severe, very, very important point, systolic will increase, of course, but diastolic will decrease. Why? Because of decrease in the total peripheral resistance. Normally, we think when we are exercising, your systolic and diastolic both will increase. It is not like that. When we are exercising isotonic exercise, remember this is moderate to severe exercise, total peripheral resistance will decrease. And why they will decrease? Because more and more muscle is going to require the blood supply. More and more muscle will require oxygen. So local metabolites on the skeletal muscle, when exercise is there, muscles are exercising, and moderate to severe exercise is there, it will cause more oxygen utilization. It will accumulate the local metabolite, and more accumulation of local metabolites will cause dilation, and that will decrease total peripheral resistance. So please do remember, during isotonic exercise, if it is moderate to severe, okay, in that condition, diastolic blood pressure will not increase, it will decrease. So answer will be local metabolites on the skeletal muscle arterioles. Clear? So during exercise, you can see here, local metabolites accumulate in the exercising muscle and cause local vasodilatation. So when there is a moderate to severe exercise, muscle will need more and more oxygen. So there will be vasodilatation. And because of this vasodilatation, all blood will pool toward the muscle, and there will be decrease in the arteriolar resistance of the skeletal muscle. And that will decrease your diastolic blood pressure. And because muscle mass is large fraction of total peripheral resistance will decrease. Therefore, skeletal muscle vasodilatation will result in overall decrease in TPR And even though there is a sympathetic vasoconstriction, a little bit mild. So mainly there is vasodilatation, decreasing total peripheral resistance. So next question, a newly developed local anesthesia blocks sodium channels in the nerve. Which of the following effect on action potential would it be expected to produce? Local anesthesia. First, you need to understand what is the mechanism of action of local anesthesia. Which channel is blocked by that? Okay, what is the first option? Decrease rate of rise of upstroke of action potential, shorten absolute refractory period, abolishes hyperpolarizing after potential, increase sodium equilibrium potential, or decrease sodium equilibrium potential. So what is the exact mechanism of action of local anesthesia? You know, local anesthesia blocked voltage gated sodium channel. And if it is blocked, voltage gated sodium channel is blocked, automatically what will come down? Sodium only. So there will decrease the rate of rise of upstroke, because you know, in case of any excitable tissue, we have a RMP, we have resting membrane potential, we have action potential, and because of voltage gated sodium channel, there will be depolarization because of the sodium influx, and repolarization is because of the potassium outflux. So depolarization will cause sodium influx, repolarization is because of the potassium outflux. So this is called as upstroke. It is called as upstroke. It is called as downstroke. So please do remember, sometimes we forget that depolarization is also called as upstroke. So in case of this question, what we see here, they are talking about the local anesthesia. Local anesthesia are going to block sodium channel. So if sodium channels are blocked, upstroke, or you can say depolarization will decrease. So there is decrease in the rate of rise of upstroke of action potential. It shorten the absolute refractory period? No. Abolishes hyperpolarization? No. Increase sodium potential? So these all are irrelevant answers. If you know the exact mechanism, you know the answer. So exact mechanism is what? Blockade of sodium channel would prevent action potential. What is the exact mechanism? Exact mechanism is local anesthesia will block voltage gated sodium channel. So upstroke of action potential depends on entry of sodium. So automatically that will be reduced. Absolute refractory period will be lengthened. Why? Because of ability to working of sodium channel. Sodium channels are not able to work. If sodium channels are not able to work, there will not be depolarization, there will not be upstroke. So absolute refractory period will increase. Okay, hyperpolarization, these are irrelevant. So this was about your local anesthesia. Now the next question, at the muscle end plate. At the end plate of the muscle, acetylcholine cause opening off. Now this is a tricky question again. It is a question where we make mistake. Okay, let me give you 30 seconds to answer this question. Then I will. At the muscle end plate, acetylcholine cause the opening of sodium channels and depolarization toward the sodium potential. You know this is correct. Potassium channel and depolarization towards potassium. No, it causes repolarization, hyperpolarization. Calcium channels and depolarization towards the calcium equilibrium potential. Is it so? Not in the, it is only the hard plateau phase. Now, sodium and potassium channel and depolarization to a value halfway between sodium and potassium equilibrium. Now tell me, what is the correct answer, A or D? If D is not given, then definitely answer will be A. But if D is given, what is your correct answer? Yes? What do you think is the correct answer? A or D? E, of course, everyone knows sodium cannot cause hyperpolarization. So I will not ask you E. It's very easy. The only thing which you have to differentiate is option is A or option is D. Whatever you think you can answer, then I will discuss. Rajan, very good. Answer is D. Absolutely correct. Normally, I've seen that they answer one. See, you know this is your neuromuscular junction. This is your neuron. This is your muscle. This is acetylcholine. And you know, when action potential is coming down, the first step is action potential at the nerve terminal. Then there will be influx of calcium. When action potential is coming down, because of opening of voltage gated calcium channel, calcium will come inside, and this calcium is required for exocytosis of acetylcholine. What is this? It is acetylcholine. It is acetylcholine. And there is a channel over here. Who will tell me the name of this channel at the end of muscle? It is called as ligand gated. It is called as ligand gated acetylcholine channels. This much you know. The first step is that influx of action potential. Second step is influx of calcium, voltage gated calcium channel. Then the third step is exocytosis of the synaptic vesicle. Fourth step is attachment of acetylcholine. Fifth step, we only discuss influx of sodium. We only discuss influx of sodium, but that is wrong. Sodium will come inside, but potassium will go. That is why the combination will generate excitatory post-synaptic potential. We only discuss that sodium will come inside, it will generate action potential, but this is the half truth. It is not the exact mechanism, and where INI CET will play the role. INI CET will ask the same topic, same question, but in more detail. We will think that we answered correct. Answer is that it's very easy answer. Acetylcholine will go, gate will open, sodium will go inside, action potential in the muscle. No. Sodium will come inside, potassium will go. And with the half of the potential, this will generate post-synaptic potential. And when they add together, only then it will convert into action potential. This is the exact mechanism. Normally, we skip this point. Normally, we discuss only sodium will come inside, generate action potential. But answer is sodium and potassium channel both will open. And this will be the halfway between sodium and potassium. So if D option is not there, in some of the examinations, they will not give you D option. Okay, so you will mark A. But in the exam, read before you think and think before you answer. Read before you think and think before you answer. So first of all, try to, yes, Swamidip, EPSP is a graded potential. Yes, absolutely correct. Absolutely correct. It is a graded potential. And this graded potential will combine together. Summation is possible in graded potential. It will combine together and produce acetylcholine and produce the action potential. That is why it is called as quantum release. If you go to the guidance say quantum release of acetylcholine. For example, 1,000 of acetylcholine molecule will come and generate. And when they combine together, only then it will generate action potential. From now onward, please add one point which is skipped in most of the books and also we don't discuss. But in a lot of examination in ICT, they have asked this question that sodium will come inside, potassium will go out, and this will generate. Now, because I am discussing this, can you tell me if there are antibody against this channel, calcium channel, what is that disease called as? Every year they will ask you this question. If antibody are against voltage-gated calcium channel, this will generate a disease called as anyone? If there is antibody, autoimmune antibody against voltage-gated calcium channel will cause Lambert-Eaton syndrome. Please, sorry for the bad throat. I'm having severe throat. Okay. So if antibody are against voltage-gated calcium channel, then it causes Lambert-Eaton syndrome. Yes, very good. And if antibody are against acetylcholine channel, then it will cause myasthenia gravis. Who can tell me the exact difference, clinical difference between Lambert-Eaton syndrome and myasthenia gravis? What is the exact difference between these two? Lambert-Eaton and myasthenia gravis. The main difference is that in Lambert-Eaton syndrome, morning is bad. He will be weak in the morning, bad morning. But as day progresses, as he will do exercise, okay, night become better. So he will gain the strength as day will progress. So he will have a bad morning and he will have good night. Bad morning and good night. So in Lambert-Eaton syndrome, he will feel weakness in the morning. He will feel weakness in the morning and he will acquire the strength by the time day progresses. So night will be okay. But in case of myasthenia gravis, yes, Soumyadeep, you are correct. Myasthenia fatigable after work. Very good. So myasthenia gravis will have good morning. He will be strong enough to do any activity. But as day progresses, okay, his strength will come down and he will have bad night. This is the most important differentiating feature between Lambert-Eaton and myasthenia gravis. Is this clear, doctor? So please remember, this is a very important point. If voltage-gated calcium channels are blocked by antibody, it is Lambert-Eaton syndrome, and they will have bad morning, good night. And if antibody are against acetylcholine channel, it is called as myasthenia gravis. They have good morning, but bad night. Okay. So now next, 8th, an inhibitory post-synaptic potential. Just now we have discussed about EPSP. Okay, and this question is about IPSP. We have just now discussed EPSP is because of influx of cation. So please tell me what is IPSP? First option, depolarizes or hyperpolarize. First, let me clear that IPSP will cause depolarization or will cause hyperpolarization. What do you think? It will cause depolarization or it will cause hyperpolarization? Yes? Anyone? Inhibitory. So it will cause hyperpolarization. Very good. Answer will be hyperpolarization. C or D. No, hyperpolarization is due to influx of cation or anion. Again, influx of cation or anion. Anion only. To hyperpolarize the post-synaptic potential by opening of chloride channel. It is chloride. So remember, doctors, very, very important point. EPSP is due to influx of cation. Cations can be sodium, cations can be potassium, but IPSP is due to either influx of anion, or outflux of cation. There are two causes. Okay, so in this question, answer will be, of course, hyperpolarization. It can be due to opening of chloride channel or can be due to efflux of cation. So either influx of anion or it can be outflux of cation. Outflux of cation. So here answer is D. You are correct. Absolutely correct. Which one of the following would occur as a result of inhibition of sodium potassium pump? Can you name the drug? The drug which is blocking sodium potassium pump. Can you name the drug which blocks sodium potassium pump? What is the name of the drug? In the pharma, we know. Answer is digitalis. Okay, good. What is the answer? A, B, C, or D? Decrease sodium, increase potassium, increase calcium, increase sodium glucose co-transporter, increase sodium calcium exchanger. You are absolutely correct, doctor. Answer is C. Very good. Your all answers are correct. Good. So you know this is your heart. Let me make a heart. Funny heart. It has sodium. Potassium pump. It also has a exchanger. What is that exchanger? Sodium calcium exchanger. Sodium calcium exchanger is present in the heart. So in the heart, On the basal side, we have sodium potassium pump, and we also have exchanger called as sodium calcium exchanger. So if I block sodium potassium pump, this will not function because secondary active co-transporter and antiporter work because of energy given by the primary pump. If primary pump is blocked, ATP will not reach to the sodium calcium exchanger. So if you block the primary pump, automatically this will not function. And doctor, if this will not function, calcium will not go out. Calcium will accumulate. So as told by Dr. Soumyadeep, excellent, very good. Answer is correct. Answer will be what? Answer will be accumulation of calcium. Because of inhibition of sodium potassium pump, because of inhibition of sodium calcium exchanger in the heart, calcium will not go outside. And if calcium will not go outside, what is going to happen, doctor? Calcium will accumulate, and this accumulation of calcium is called as increase in the force of contraction or positive inotropy. Positive inotropy. Increase in the force of contraction is called as positive inotropy. Now, please tell me, increase in the heart rate is called as, answer will be positive chronotropy. Chronotropy. Increase in the heart rate, chronotropy. Increase in the force of contraction, inotropy. What is increase in conductivity? Increase conductivity. What is the answer? One is inotropy, force of contraction. Other is heart rate, called as chronotropy. What is conductivity? Anyone? It is called as positive dromotropy. Dromotropy means conductivity. Now, if there is increased excitability, what is this called as? Increase excitability is called as, anyone? Heart rate, chronotropy. Force of contraction, inotropy. Heart rate, chronotropy. Conductivity, dromotropy. Excitability. If there is increased excitability, for example, someone has taken 10 coffee together and he started having ectopics. What is that called as? It is called as bathmotropy. Bathmotropy. So increase in the excitability is called as bathmotropy. Now, last, what is increase in the last? What is increase in the relaxation of the ventricle called as? The last. It is called as positive lucitropy. Positive lucitropy. So force of contraction, inotropy. Heart rate, chronotropy. Okay. Excitability, bathmotropy. So these all are terminologies for your heart. Now, next question. Which of the following temporal sequence is correct for excitation contraction coupling in skeletal muscle? Every year they ask you the sequence of neuromuscular junction. They will ask you sequence of excitation contraction coupling. You must know what are the steps. But before going in the discussion, please answer the question. What is the answer? Increase calcium action potential in the muscle cross bridge, or action potential in the muscle membrane, depolarization in the T-tubule, release of calcium from reticulum, or action potential in the muscle membrane, splitting of ATP, or release of calcium from reticulum. What is your correct answer? A, B, C, or D? What is the correct sequence? It is a repeat MCQ from INI CET. What is the correct answer? Yes. Very good. Very good answer. Excellent. So all of you are correct. That's very nice. So you know this is your excitation contraction coupling diagram. This is the T-tubule. This is sarcoplasmic reticulum. If you know that. Okay, now tell me, what is the receptor present on T-tubule called as? And what is the receptor present on the reticulum called as? On the T tubule, we have dihydropyridine receptor. It is a type of L-calcium. It is a type of L-calcium. So on the T tubule, we have dihydropyridine receptor. And on the reticulum, we have ryanodine receptor. We have ryanodine receptor. Inside the sarcoplasmic reticulum, there are lots and lots of calcium which are present inside the reticulum, and they are binding with what? Which protein? Cal binding, calsequestrin, calmodulin. What is the answer? Answer is calsequestrin. Repeat MCQ. Calsequestrin. Calsequestrin is a protein that has binded with calcium inside sarcoplasmic reticulum. Okay. Now, first of all, let me ask you, when action potential come inside, there will be talk between DHPR and ryanodine. There will be a communication between dihydropyridine and ryanodine receptor. Okay. This talk is physical or chemical? This is your NEET PG question. The communication between dihydropyridine and ryanodine, it is a physical conformational change or only a chemical talk? Who can answer my question? Yes, anyone? Is it a physical or a chemical? What do you think? When action potential come inside the T tubule, there will be a talk between DHP. Yes, Somadev, you are absolutely correct. Mechanical talk. Excellent. Most of you are thinking that this is a chemical talk. It is a mechanical talk between DHP and ryanodine, and this will cause release of calcium. And this calcium will attach with troponin C to cause conformational change to uncover. There will be conformational change to uncover myosin binding site on actin filament. So when calcium attaches to troponin C, there is a conformational change to uncover myosin binding site on actin filament, and this will cause muscle contraction. Now, contraction is the active process, but after that, calcium will also go inside. So relaxation is an active process or a passive process? Remember, doctor, relaxation is also active process. It is also an active process. Calcium is going inside with the help of a pump called as SERCA. What is SERCA? Sarcoplasmic endoplasmic reticulum calcium ATPase. So not only contraction, but relaxation is also an active process. Because relaxation is due to influx of calcium. Only when calcium will go inside, muscle can relax. So the sequence will be number one, action potential will come, then mechanical torque, then calcium will come outside. It will attach to troponin C and cause actin myosin contraction. So answer is absolutely correct. Answer is B, action potential in the muscle membrane. D, polarization of the T tubule, release of calcium from sarcoplasmic reticulum. Now one more question. Mutation of ryanodine can cause a disease. What is that disease called as? Mutation of ryanodine. If there is a mutation of ryanodine, it will cause, what is that called as? Answer is MH. Mutation of ryanodine will cause malignant hyperthermia. It will cause malignant hyperthermia. So if there is a mutation of ryanodine, more and more calcium will be released, and those calcium will cause excessive muscle contraction, and they will generate the heat. Yes, Harsha, you are absolutely correct. Answer is malignant hyperthermia. Absolutely correct. Now, can you tell me the drug of choice of malignant hyperthermia? What is the exact drug of choice of malignant hyperthermia? Answer is dantrolene. Answer is dantrolene. Dantrolene is the drug of choice of malignant hyperthermia. So answer is action potential in the muscle, depolarization of T tubule, release of calcium, And this is the sequence. After that, calcium will attach to troponin C, cause conformational change, and uncover myosin binding site on the actin, and contraction will happen. It is called as excitation contraction coupling. Next question. What is the answer? Yes, you are correct. Answer is dantrolene. Which of the following transport process is involved if transport of glucose from intestinal lumen into small intestine is inhibited by abolishing usual sodium gradient? See, every year one question will be from sodium glucose transport or simply glucose transport. They will ask you one question every year in NEET PG and INI CET because they know that we get confused between SGLT and GLUT. That is why they keep on asking about GLUT and SGLT. Now tell me what is the answer. Which of the following transport process is involved if transport of glucose from intestinal lumen? The first you should know they are talking about SGLT or GLUT. Yes, very good. Answer is D and B. Okay. This is, see, even then we make mistake in the exam. Why? Because of lack of practice. See, SGLT. SGLT. Intestinal glucose absorption is by SGLT. SGLT1 is present only in intestine. SGLT1 is present only in intestine. On the other hand, in kidney, we have SGLT1 as well as SGLT2. SGLT is the active transport whose transport is because of secondary to sodium absorption. So answer is secondary active transport. It is symport or antiport? Symport. Symport. It is symport. Yes, you are correct. Symport also called as co-transporter. Co-transporter. So answer will be co-transporter. Yes, all of you are correct. Answer is co-transporter or symporter. But remember, in intestine, we have only SGLT1. In kidney, we have both. 90% of glucose transport from the kidney is by SGLT2. Only 10% is by SGLT1. Only 10%. So for kidney, SGLT2 is very important. More than 90% absorption is by SGLT2. Only 10% is by SGLT1. That is why in diabetes, we give SGLT2 blocker. In diabetes, we use SGLT blockers. Can you name some of them? Canagliflozin, dapagliflozin, empagliflozin. So these are acting on PCT. You are absolutely correct, doctor. They act on PCT, of course, and they will block SGLT2. So they have a better understanding. Why? Not only glucose, but sodium will be released in the urine. So they will not only decrease your sugar, blood sugar, but also decrease your BP, also decrease your body weight. That is why they are considered nowadays very important drug for diabetic, SGLT2 blocker. Okay, so one mechanism of transport is secondary active transport. Other is facilitated diffusion. And for that we have a carrier protein called as GLUT. We have carrier protein called as glucose transporter. It is active or passive, doctor? It is passive. SGLT is active. This is passive. Very simple. Now, GLUT1 is present in blood-brain barrier. GLUT1 is present in RBC. It is also present in placenta. GLUT2 is present in, the mnemonic is beta cell-like. Beta cell-like. What is like? Liver, intestine, and kidney. Liver, intestine, and kidney. Okay. Beta cell-like. GLUT2. GLUT4. GLUT4 is present in anyone? GLUT4. GLUT4 is the only GLUT that is insulin dependent. The only GLUT that is insulin dependent is called as GLUT4. and it is present in two places. One is your skeletal muscle and one is adipocytes. Then GLUT5, F for 5, F for fructose. F for 5, F for fructose. GLUT5 is present in fructose, for fructose. Now, next question, in skeletal muscle, which of the following event occur before depolarization of the T tubule? Just now we have discussed. Before action potential coming in the T tubules, where they are present. What is the answer? Depolarization of the sarcolemma, opening of the calcium release channel on the reticulum, uptake of calcium into reticulum, or binding of calcium to troponin C, or binding of actin myosin. Just now we have discussed the same question. Before entering the T tubule, where are they present? Before entering the T tubule, they will be at the layer of membrane, sarcolemma. So what is the answer? Before entering the T tubule, we have seen in that diagram, depolarization was of sarcolemma membrane. So what is the correct answer, doctor? A. Depolarization of the sarcolemma membrane. Next question. Blood level of which of the following substance is decreased in the grave disease? Blood level of which of the following substance is decreased in the grave disease? T3, T4, DIT, TSH, or iodine? It's very simple question. You know that. What is the answer? Grave disease is a thyrotoxicosis, hyperthyroid drug. Hyperthyroid disease, I mean not drug. It is a hyperthyroid. It is a hyperthyroid situation. So when there is a hyperthyroid, okay, whenever T3, T4 is more, it will cause inhibition of TSH. Yes, both of you are correct. Very good. All of you are correct. Answer is, who will be low? TSH, thyroid stimulatory hormone. Now, can you tell me which antibody is diagnostic for grave disease? Is it anti-TPO antibody? Which antibody is diagnostic for grave disease? Is it TPO antibody or TSI, which is also called as TRAP? TSI, TSH stimulatory immunoglobulin, also called as TRAP. Which antibody is diagnostic for hyperthyroid? TPO antibody or TSI, which is also called as TRAP? What is the answer? Yes, very good. Excellent. Long-acting TSI. TSI are pathognomic of grave disease. TPO can be in any disease like Hashimoto also, grave also. It is non-specific. It is therapeutic. Diagnostic? No. It is not diagnostic. It is therapeutic. Okay. TSS receptor. Both of you are correct. Yes, TPO is for Hashimoto. You are absolutely correct. But remember, doctor, it is not diagnostic. If TPO is present, it does not mean patient is having Hashimoto. It can be in Hashimoto. It can be in other disease also. So it is non-specific. But TSI is specific. Which of the following hormone act by IP3 DAG calcium mechanism? I mean GQ receptor. Simply they are asking about which hormone act on GQ receptor. Vitamin D3, progesterone, insulin, parathormone, or GnRH. Every year, 1 or 2 questions will be only from receptor physiology. What is the answer? If you remember one line I have given, if you remember that line, you will not forget. What is that line? Very good. Answer is E. Answer is E. That line is all releasing hormone. All. Whenever at the end you have releasing hormone, all releasing hormone are GQ receptor except CRH, because CRH is GS. When you are having RH at the end of any hormone, gonadotropin releasing hormone, growth hormone releasing hormone, okay, all releasing hormone except CRH. CRH, corticotropin releasing hormone, is the example of GS. Rest all are GQ. Okay. Vitamin D3, where is the receptor? Nucleus, progesterone, cytoplasm. Insulin. Insulin act on which receptor? Anyone? Receptor. Remember, doctor, insulin. Insulin. Insulin plus all growth factor. All growth factor except TGF beta are example of receptor tyrosine kinase. One line will help you in understanding all examples of tyrosine kinase receptor. What is that line? Insulin plus all growth factors. It can be platelet-derived growth factor. It can be nerve growth factor. It can be endothelial growth factor. Whatever, except TGF beta. Except TGF beta. Okay. TGF beta is an example of what? TGF beta is the example of serine kinase. Yes, very good. Very good. Soumya, if you remember this line, except serine threonine kinase, it is TGF beta. One more example I want to, one more line that will help you in remember the example, and that is your JAK-STAT pathway. How to remember hormones of JAK-STAT pathway? JAK-STAT pathway, also called as cytokine pathway. Yes, also called as tyrosine kinase associated receptor. That was tyrosine kinase receptor. Insulin plus all growth factor was tyrosine kinase. And this is tyrosine kinase associated receptor. And examples are very simple. What are the examples? Growth hormone plus altin, erythropoietin, thrombopoietin, leptin, and what else? Erythropoietin, thrombopoietin, leptin, and prolactin. Prolactin. Okay. So growth hormone plus all the tin except somatostatin. Okay. Don't say somatostatin. All the tin like prolactin, thrombopoietin, erythropoietin. Okay. And leptin. You know, leptin is from your fat. It gives you the hunger. It also have influence in puberty. Okay. Anyway. So for tyrosine kinase receptor, insulin plus all growth factors except TGF beta. For JAK-STAT, what are the examples? Growth hormone plus altin, prolactin, thrombopoietin, erythropoietin, and leptin. These all are example of JAK-STAT pathway. I hope you will not forget now. And because all growth factors are acting on tyrosine kinase receptor, so tyrosine kinase blocker is used in which disease? Tyrosine kinase blocker. Can you name some example of tyrosine kinase blocker? Imatinib mesylate, dasatinib mesylate. They are acting on tyrosine kinase. They are tyrosine kinase blocker. So they can be given in CML. They can be given in GIST. So chronic myeloid leukemia, because directly you are acting on what? Tyrosine kinase receptor. Okay. So they are given for CML. Yes, very good. Imatinib mesylate and dasatinib mesylate. Which of the following cause increase in aldosterone? Which of the following will cause increase in aldosterone? Yes. Which of the following will cause increase in the aldosterone? Decreased blood volume, administration of inhibitor of ACE, hyperosmolarity, and hypokalemia. What is the answer? Which of the following will cause increase aldosterone secretion. What is the answer? So A, decrease blood volume. Yes, very good. Hyperosmolarity, uh, A. So most of you are saying A. Any other answer? Is there any other answer? Okay, most of you are correct. Answer is A only. C. Aldosterone, if you remember, aldosterone is from, there are three: zona glomerulosa, zona fasciculata, zona reticularis. Glomerulosa is releasing aldosterone. Fasciculata is for salt, for sugar hormone, and this is for testosterone and estrogen. Now, which is the only layer that is not controlled by pituitary gland? Answer is zona glomerulosa. It is not controlled by pituitary gland. That is why if there is a pituitary surgery, there is no need of replacement of aldosterone, because aldosterone is mostly activated by hyperkalemia and then hypovolemia. Hyperkalemia and hypovolemia, because most important function of aldosterone is to secrete the potassium. Most important function of aldosterone is to secrete potassium and reabsorb sodium. So whenever potassium is high, it will immediately secrete potassium. Why? Potassium decreases RMP. It can stop the heart. We discussed so much in detail about hyperkalemia, hypokalemia. They are very dangerous. When there is a hyperkalemia, RMP will decrease. It will come near to the threshold. It will decrease. It will damage voltage-gated sodium channel. Action potential will not come. Heart will stop. It's a very, very important topic. That is why we give calcium gluconate to stabilize the membrane. Why calcium gluconate is given? To stabilize the membrane. The most important electrolyte problem is your potassium. Hyper will decrease RMP, hypo will increase RMP. And who is going to tackle? Aldosterone. So answer is not hypokalemia. Some of you, okay, you are in hurry and you say hyperkalemia. Number one, if hyperkalemia is not present, then decrease blood volume. Decrease blood volume. Okay, they will absorb sodium, so water will come automatically. So the most potent stimulus for aldosterone release is hyperkalemia, doctors. It is the most potent, because aldosterone is prepared always. Whenever potassium become a little high, I have to secrete the potassium so that RMP should not decrease, heart should not stop. So from now onward, always remember, hyperkalemia is a very dangerous thing. It can stop the heart by damaging voltage-gated sodium channel. And this phenomenon is called as accommodation. We have discussed in much detail, accommodation and all. Okay. Now, secretion of oxytocin is increased by milk ejection, dilation of cervix, increased prolactin, increased ECF, increased serum osmolarity. What is the correct answer, doctor? Oxytocin secretion is by milk ejection, cervical dilation. Please participate in the chat. Everyone should answer. I always say you have, okay, quota of blunders. We all have quota of blunders. Always finish that before examination. And how to finish that? By participating in the MCQ, okay, by answering in your class. Because when you make mistake, definitely that question will not be wrong in your exam. When someone is wrong, I'm very happy, because now in the exam, he will never be wrong. If you say wrong answer, okay, automatically you are corrected forever. Happy Deepavali, Yashin Khan. Happy Deepavali. I'm very happy that even in the Deepavali, you all are coming. What is the answer? Anyone? Achan Khan say B. Okay. Any other answer? One thing is for sure, you all have done very good revision. Because normally when I ask this question, they say milk ejection. Milk ejection is actually done by oxytocin. Okay. Dilation of cervix is the stimulus for dilation of cervix is the stimulus for secretion. It again causes dilation. It is called as positive feedback mechanism. Positive feedback mechanism. So oxytocin is released either by nipple stimulation or by breastfeeding or by dilation of cervix. So these are the important stimulus, and it also causes milk ejection and dilation. So it is a type of positive feedback mechanism. So answer is B, not A. Very good. Answer is B. Okay. A 61-year-old woman with hyperthyroid is treated with propyl thiouracil. The drug reduces the synthesis of thyroid hormone because it inhibits oxidation of. What is the answer? T3, T4, DIT, TSH, or iodide? What is the correct answer? This question is very important because every year one question will be from thyroid hormone synthesis. Propyl thiouracil inhibit which enzyme? Propyl thiouracil inhibits which enzyme? Yes. It inhibits which enzyme? Sorry. TPO. TP. And TPO causes three action. Three action are caused by TPO. One is, please answer without hesitation. One is oxidation of iodide into iodine. The first action of TPO is what? Oxidation of iodide into iodine. Second is organification. Second is organification of iodine forming MIT and DIT. Third is coupling. Coupling will form either T3 or T4 or reverse T3. Remember, doctor, all these three actions are done by TPO. And this TPO is blocked by anti-thyroid drug. Methimazole, carbimazole, propyl thiouracil, they act on TPO. Even in Hashimoto, we see TPO antibody. One TPO has multiple action. Oxidation of iodide, number two, organification, and number three is coupling. So question is about the drug will cause, it will inhibit oxidation of T3, T4, DIT, TSH. Very good. Most of you are correct. Answer is E, iodide. Excellent. Very good. So answer is iodide. Iodide is converted into iodine. By TPO. And TPO is the target for the drugs like propyl thiouracil. In the first trimester, we use propyl thiouracil, then methima, carbimazole. You know all those things. You must know the exact action. Three actions. Oxidation of iodide, organification, and coupling. I hope this is clear. Answer is E. Which of the following substance will inhibit gastric emptying? Secretin, gastrin, cholecystokinin, VIP, and GIP. This is again often repeated MCQ. Often. Some questions are coming almost every alternate year. I don't know what is so important in that, but some questions are very favorite of examiners for Viva, for MCQ. So this is one of those GIT question. What is the answer? I will give you 15 seconds to answer. Secretin, gastrin, CCK, VIP, or GIP? Gastric NBT peptide, vasointestinal peptide, CCK, gastrin. What is the answer? And please don't hesitate in marking wrong. I'm very happy if you're wrong in the class, in the exam, and not in the exam, in the class, in the discussion. Because once you are wrong, definitely in the exam, you will never be wrong. Mind it. One question is rank deciding. Even one question will decide the rank. And we usually skip the GIT. But I discuss a lot in GIT because it is one of the most important. Yes, what is the answer? D, E. Okay, now let me clear your doubt. First doubt is that some of you are saying GIP. Name is saying gastric inhibitory peptide. It is a misnomer, doctor. It is a misnomer. Actually, the new full form of GIP is what? What is the new full form? Glucose dependent insulinotropic peptide. GIP, when it was discovered, okay, it was their misunderstanding. They thought that it will inhibit the GI motility. So they named GIP. But it is an incretin, very good, excellent, Achand Khan. It is an incretin hormone. It is an incretin hormone that releases insulin from beta cell. So GIP and GLP. GIP and GLP. What is GLP? Glucagon-like peptide. So GIP and GLP. GLP is from L cell. GIP is from K cell. GIP and GLP both are incretin hormones that act on beta cell of pancreas to release insulin. So this doubt should be gone forever. You should not make mistake now. That is why in diabetes, we give GLP-1 agonist. In diabetes, we give GLP-1 agonist to release insulin like exenatide, like liraglutide, like semaglutide, exenatide, liraglutide, semaglutide. And these all are subcutaneous injection. Only one is available in oral form also. What is that? Anyone can answer me? Can anyone answer me the only available oral GLP-1 agonist? The only available oral GLP-1 agonist. Lira, Sema, exenatide. Which glutide, which GLP-1 agonist given in diabetes? Normally they all are subcutaneous, except one. Anyone can answer me? Answer is Sema. Semaglutide. Very good, Somin. Sema. Yes, very good. Achangan, very good. Normally, GLP-1 agonist, the only problem we are not using because they were subcutaneous injection. But now we are using because they are oral, although they are costly. So remember, doctor, always GIP. So now I think you will not forget, after so much of discussion, now you will not forget GIP and GLP are incretin hormone. Clear? Now, VIP and nitric oxide, they are for relaxation. If you remember, we have discussed about the peristalsis. Contraction, relaxation. Contraction, relaxation. Contraction is done by acetylcholine and substance P. Do you remember acetylcholine substance P? Relaxation is done by nitric oxide and VIP. So now you will not forget about VIP and nitric oxide. VIP and nitric oxide is for relaxation. Yes, Achangan, you are very much updated. You know also the brand name, very good. Although it's very costly, you know that. But at least now one GLP-1 agonist is there, that is oral. Excellent. I'm very happy you know such detail about this. Okay, very good. So VIP and nitric oxide is for relaxation. Cholecystokinin. When they say cholecystokinin, we always think about cholecyst, gallbladder contraction. And that is why they are asking this question. It is not only for gallbladder contraction, It is also inhibit gastric emptying. See, the answer is C. Answer is C. Cholecystokinin is most important hormone for digestion absorption of fat. In addition to causing contraction, it inhibits gastric emptying. That is why they keep on asking this question, because we used to make mistake. Only those questions are repeated when we make mistake. They will see, and they will see that a lot of students are making mistake. They will repeat the question. So remember, doctor, CCK is the answer now. The hormone which will inhibit gastric emptying, his answer is cholecystokinin. So cholecystokinin will cause contraction of the gallbladder, relax sphincter of the aorta. It also increase pancreatic secretion. That is why full name is cholecystokinin pancreozymin. Cholecystokinin pancreozymin. It releases pancreatic secretion. And the third function is it inhibit gastric motility. It inhibit gastric emptying. Clear? Gastrin, you know, in the antrum of the stomach, G cell, it is important for HCl secretion. Secretin is like antacid. It is a natural antacid producing bicarbonate. It is the first hormone which was discovered by Baylis and Starling. The first hormone in the body which was discovered, secretin, by Baylis and Starling. And Starling has also given the term hormone. Okay, so secretin is like a natural antacid. To counteract about the acid, secretin will secrete more of antacid. Gastrin from G cell, it is opposite of secretin. Which, when parietal cells are stimulated, they will secrete what? What is the answer? I'm really sorry for my bad throat today. I cannot speak much. My voice, I hope my voice is clear to you. What is the answer? When parietal cells are stimulated, they will secrete HCl, intrinsic factor. Yes, so very obvious answer. Everyone knows about that. HCl and intrinsic factor, doctor, very good. And if antibody are against this cell, if antibodies are present against parietal cell, what is that called as, doctor? You know, pernicious anemia. Pernicious anemia, because intrinsic factor is important for absorption of vitamin B12. So if antibody, remember, pernicious anemia is a autoimmune disorder. Suppose there is a gastrectomy and you remove the stomach and intrinsic factor cannot be released. So can you say pernicious anemia? No. Until you get antibody against parietal cell. Because of the antibody, okay, intrinsic factors are not secreted and it is called as pernicious. Which of the following is a step in photoreception in the rod? Anyone? Light convert. First answer, then I will explain. Again, I'm telling you this question is very important. Vision pathway, vision physiology, vision transduction is very important. What is your answer? Yes, what is the answer, doctor? Please tell me. Light convert trans into cis. Okay, let me correct that. Cis into trans. A is wrong. So A is wrong. First option is wrong. Okay. Cyclic GMP level increases. No. You are correct from me. It does not increase. It will decrease. Very good. Rod will depolarize. No, it is the only exception. Normally, when you activate, there is a depolarization, but there is hyperpolarization. This is also wrong. Hyperpolarization. Glutamate will increase. Again, exception. Glutamate will decrease. So answer is B. Meta-rhodopsin 2 activate transduction. Let me explain this diagram. Again, very important. Rod and cones have important channel called as cyclic GMP cyclic GMP. Cyclic GMP. Sorry, it is P. Dependent sodium channel. So in the dark, what happened in the dark? Dark, when there is dark, no, Amavasya, today is Amavasya. When there is dark everywhere, okay, cyclic GMP sodium channels are open. What will come inside? Sodium. It is called as dark sodium current. It is called as dark sodium current. And this will cause depolarization. In the dark, there is depolarization. You know, today is Deepavali and there's a dark and we are lighting the lamp. It is similar to your vision. We light the lamp when there is dark. Similarly, when there is dark, there is depolarization. Opposite is happening here. Okay. And this will cause increased release of glutamate. This will cause increased release of glutamate. So in the dark, glutamate is more. Everything is opposite. In the dark, glutamate is more, and this more glutamate is going to inhibit ganglion cell. Everything is paradoxical. That is why they keep on asking this. So in the dark, there is depolarization. In the dark, glutamate is more. In the dark, when glutamate is more, it is the excitatory transmitter. So normally it excites. But here, increase in glutamate will inhibit your ganglion cell. In the light, cis-retinol convert into trans. How? By a cycle called as PLMM. PLMM. Bathmo-rhodopsin will convert into lumi-rhodopsin, into meta-rhodopsin 1, meta-rhodopsin 2. Meta 1 and meta 2. This meta 1 and meta 2 will activate trans-retinol and this will form transducin. This was the correct option. Transducin will convert cyclic GMP into GMP. See, everything is opposite and this channel will close and now instead of depolarization, there will be hyperpolarization. And hyperpolarization will decrease release of glutamate and the decrease in glutamate release will cause activation of ganglions. So please do remember, it's very, very important called as phototransduction. So the correct answer is meta-rhodopsin 2 activate transducer. Clear? This is about your 20 questions. Now, 2-3 questions more. Pathogen that produce fever causes. Just let me ask you 2-3 more questions. They are very important for your exam, especially INI CET. Decreased production of interleukin, decreased set point, shivering, or vasodilation. What is the answer? You know 3 functions. When there is a fever, set point is increase. Set point is increase. And you can see here, you can start shivering. And there is vasoconstriction. So during fever, increase in the set point, not decrease. Increased production of interleukin, not decreased. Shivering, yes. Vasodilation, no. Vasoconstriction. Vasoconstriction. So when there is a fever, set point will increase. Vasoconstriction and shivering is the correct answer. Okay. This we have done already. Okay. Which of the following cause a decrease in renal calcium clearance? Which of the following will cause decrease in renal calcium clearance? Last question of the day. Hypoparathyroid, treatment with hydrochlorothiazide, treatment with furosemide, ECF volume expansion, or hypermagnesemia. What is the correct answer? Yes, excellent. Some students are such fast, they're so fast. Even you answer before I can think. It is showing your level of dedication. Any other answer? Yes, very good. Loop loses calcium. Wonderful. Loop loses calcium. Loop diuretic, furosemide, torsemide, ethacranic acid. Loop loses calcium. Very good. And thiazide decreases losing. The answer will be, of course, very good. B. Excellent. Thiazide block which channel? NCC. What is NCC? Sodium chloride channel. Furosemide block which channel? NKCC. Sodium potassium 2 chloride channel. Mutation of NCC causes what? Gentleman syndrome. Mutation of NKCC causes what? Bartter syndrome. Bartter syndrome. So loop loses calcium. Wonderful. Harsha. So calcium will be lost. That is why in Bartter syndrome, we have recurrent nephrolithiasis. The clinical presentation of Bartter syndrome is recurrent nephrolithiasis because in the Bartter syndrome, it is blocking the same channel like loop diuretic. Loop diuretic block NKCC and Bartter is due to mutation of NKCC. So clinical features of Bartter will be like side effect of loop diuretics. And that is why thiazides are given as a treatment for nephrolithiasis. That is why thiazides are given as a treatment for nephrolithiasis. Wonderful. So very good. All of you are very well prepared. All the very best for your exam. And thanks for joining me in this auspicious occasion of Deepavali. Happy Deepavali to everyone. May God bless you all. So thanks. For any doubt, you are most welcome on Telegram group. Okay. So thanks a lot. Thank you. Bye bye. Take care. If you want to ask any doubt, you can ask me. Thank you. Thank you, Soumya. Thank you, Harsha. Thank you, Achan Khan, everyone. Bye bye. Take care.